بنتوجه بالشكر الجزيل للأستاذة الدكتورة سونيا الشرقاوي والأستاذ الدكتور أسامة عرفة على دعوته الكريمة لرابطة أطباء أطفال دمياط. كما أتوجه بالشكر لوجودي في المنصة الكريمة مع الأستاذ الدكتور وائل بحبح والأستاذ الدكتور محمد سنون وأخويا الكبير الأستاذ الدكتور عثمان الشواحي صاحب أول مؤتمر في دمياط. وبننتهز هذه الفرصة لدعوتكم لمؤتمرنا السنوي 21 إن شاء الله في الخميس الثاني من شهر سبتمبر. شرف كبير جدا ليا ان اقدم استاذتي واستاذتنا الغاليه واحده من البيونير في الدايابيتس والاندوكراين الاستاذ الدكتور رشا طريف، والمحاضره بعنوان تايب 1 دايابيتس ميليتس ان تشايلدهود اند انف.
بسم الله الرحمن الرحيم. بشكر الدكتور باسم على التقديم الجميل، وبشكر الاستاذه الدكتوره سونيا، دكتور اسامه، دكتور ممدوح. الحقيقه مش عارفه اشكر مين ولا مين على كرم الضيافه والاستقبال الجميل والرحله اللطيفه اللي استمتعنا بيها. هتكلم عن التايب 1 diabetes in children and adolescents، والحقيقه انا حطيت لها عنوان shall we take the challenge because it's really challenging to treat type 1 diabetes. It's easy to diagnose but it's difficult to treat and manage in all aspects. I'll start by opening the scene, a very common scene that we as general pediatricians see at our clinics, not only as pediatric endocrinologists. And this is a very common scenario. We have a parent of a child with newly diagnosed type 1 diabetes, having a lot of questions in mind. And the problem is when the parents need fast and solid answers to these questions. وزي ما حضراتكم هتشوفوا these are the frequently asked questions by the parents. Does my child really have diabetes? They don't believe it at the beginning. Is it a lifelong disease? Could it be transient? Is it genetic? Should his or her SIBs be screened for diabetes? Is it insulin for life? Will he or she suffer from long-term complications? Really disastrous and difficult questions to answer. And here, is it a long way? And is it a lifelong disease and therapy? These are the questions asked by the parents. And the real problem is that the answer is unfortunately yes. This is the answer. And at this point, when we say yes, this is what the patients and the parents think. Diabetes means bad diet, stressful lifestyle, stress, no exercise, and a total family destruction. As this photo shows you, the patient and the parents, they are like lost at the middle of the sea. Where are we going? Type 1 diabetes. And the impact of diagnosis of a diabetes for a lifetime means anger, sorrow, grief, and anxiety, fear, isolation, depression, behavioral changes, ending up by family dysfunction. So it's not only the child, it's a whole family problem. And our aim as pediatricians and diabetologists is to change this concept. And that's why we should take this challenge. And to take the challenge, we should find solution for the patient and for the parents and the whole family. So what is type 1 diabetes? If we speak generally, diabetes means sweets, insulin, carb counting, sugars, education, hospitalization, complications, a lot of problems that we put together. Really miserable children and their families are. And the natural history of type 1 diabetes is that there is a genetic predisposition, and then there is a viral trigger triggering an autoimmune disease causing beta cell injury, insulinitis, then passing to prediabetes with impaired blood sugar, and ending up by manifest type 1 diabetes. And when those children manifest, about 15 to 20% of the beta cells are left. So it's a complex disease, immunologic, genetic, and environmental complex. And we all see, even in our clinics, that it's a growing problem. Type 1 diabetes cases are increasing in the incidence and the prevalence. And it's a growing worldwide problem. And even when we focus on Egypt, type 1 diabetic cases are increasing more and more. Even in the Middle East and African countries, the incidence is rising year after year. And Egypt is one of the top 20 countries in the MENA region having children suffering from type 1 diabetes. About 7.5 million cases recorded in 2013. Of course, diabetes is a serious chronic disease having a lot of complications, as you see: diabetic retinopathy, neuropathy, nephropathy, cardiovascular, stroke, and even a long list of other complications that need time to say. And this shows you the heavy burden of diabetes. It's not a simple disease. It's a complex disease with a lot of complications. And early maintained glycemic control is the key to reduction of long-term complications. And this is the message that we need to explain to the patient and the parent. And then the question of the diagnosis: is it pre-diabetes? Is it type 2? Is it type 1? Testing the tests. This is the diagnostic point. And these are the updated American Diabetes Association guidelines, putting the categories for diagnosis. First, we have the pre-diabetes, when the fasting blood sugar ranges from 100 to 125 milligrams per DL, impaired fasting glucose, the 2 hours postprandial blood glucose from 140 to 199, and the A1C from 5.7 to 6.4. This is the pre-diabetic range, and sometimes we see the patients at this range. And then we have the criteria, the clear-cut criteria for diabetes itself, when the A1C is more than 6.5, the fasting blood sugar above 126, and the 2-hour plasma glucose above 200, or the random blood sugar above 200. So this is the diagnosis of diabetes. The next question: is it type 1 or type 2? And surprisingly, type 2 is starting to increase because of the high incidence of obesity. So we are starting to have type 2 diabetes in children as well. If you look at this table, we have type 1, type 2, and the MODY or the genetic diabetes. Suspect type 1 diabetes in preschool children. Mostly they are not obese, although not in all cases. Male to female ratio is equal. Could be found in relative, predominantly Caucasians. In 85% you can find the beta cell antibodies. The C-peptide is low. Frequently they present with ketoacidosis and could be associated with other autoimmune disorders like Addison, thyroid, celiac, and other forms of autoimmune disease. And this is a very simple algorithm which could help in the diagnosis of the type of diabetes. Simply look at the patient: is the child obese or not? Not obese with positive antibodies, think of type 1. And if obese with low C-peptide and positive antibodies, think of type 1. So presence of an obese child does not exclude type 1 diabetes. So again, you are confirming by the antibodies. And let's put these together in one slide. Making the diagnosis of type 1 diabetes: of course, the classical symptoms that we all know: polyuria, polydipsia, DKA, random blood sugar above 200, fasting above 126, and glucose tolerance above 200, decreased C-peptide less than 0.8, and the presence of autoantibodies, and most important of which is the anti-GAD antibodies. So, is it really that simple, putting the data together in one slide and saying it's type 1 diabetes? Of course not. There are some barriers in accurate classification of type 1 diabetes, because 20 to 25% of newly diagnosed type 1 diabetic cases are obese. So why not? It could be type 2 or type 1. More than 15% of the population have positive family history of type 2 diabetes, so there is an overlap. And there is a threefold increase in the family history of type 2 diabetes in those with type 1. Again, overlap in the C-peptide measurement in the first year, and 10 to 30% of type 2 have diabetes-specific immune marker. So I think you've heard of what we call the 1.5 diabetes, the one between type 1 and type 2. So sometimes you can find a type of diabetes with overlapping symptoms from 1 and 2. And more than 30% have ketosis at the disease onset, even in type 2, although not common. And this shows you the complexity of diabetes. It's not that simple to diagnose or to treat. And when we look at the management of type 1 diabetes, I chose this photo because this is really what we are going through. It's an interconnected pathway, each thing leading to the other. It's really difficult, vicious circle, interconnected together. And to simplify matter, we need to give insulin therapy, diet adjustment, regular exercise, education, and psychotherapy. And now hold on, is it that easy putting these things together and saying, okay, we are managing type 1 diabetes? Of course not. It's not easy at all. Because you need to maintain a balance between good glycemic control, behavioral and emotional stability as well. You need to make the patient feel as if they are normal, because the psychological state is really important. It's essential to overcome management difficulties, maintaining health, balance, and happiness. And this is a very difficult equation to deal with in those patients. So let me tell you some diabetes stories to see the impact of psychological state in those patients. This is Ahmed. He's a 4-year-old boy who was recently diagnosed with type 1 diabetes. He fights blood glucose testing and insulin injections by screaming, hiding, and clenching his fists. How can the patients and the parent cope with this challenge? And this is an adolescent, Yusuf, a 15-year-old boy, out of control, type 1 diabetes. He was hospitalized for the 3rd time in the past 1 year with DKA because he doesn't take the insulin. He doesn't want to take the medication anymore. And when he was asked later, why did he stop taking the insulin? He said that he's very angry with the disease and that he loves to take sugary and sweety things and he doesn't want to take the insulin. And this is Fatma, an 18-year-old girl who is frequently admitted with attacks of hypoglycemia because she over-injects herself with insulin to eat the sweets and the carbs that she likes. And I'm sure every one of you has got a lot of other diabetes stories, which are really sad stories. Because if you look at the daily life of a diabetic child, every day in diabetic child's life makes them feel different from their peers, which makes the management even more difficult. And there are challenges in the treatment of type 1 diabetes, the multiple injections of insulin, the blood glucose testing, normal growth and development, normal puberty, avoiding complications, the family dynamics, the moral and emotional considerations. A very long list of challenges. And this is how we look like. When managing type 1 diabetes, every step counts because the diabetologist or the pediatrician is the leader, and the patient and the parents and the whole family follow. So it's very important to count every step. But the problem is when type 1 diabetes is not properly controlled, this is how it looks like, as if our patient is jumping in air. If you don't control properly, everything will go down. We need collaborative, integrated diabetes management team, with the patient being surrounded by a diabetologist, a dietitian, an educator, a pharmacist, insulin pump technologist if you're using it, psychologist, and a diabetes specialist nurse. We need an integrated team. Again, we need an integration between the school, the parent, the child, with the diabetologist being in between. When we speak about insulin therapy, this is the ADA guidelines update for insulin therapy in type 1 diabetes. The dose is 0.4 to 0.8 units per kg per day. Of course, we need higher doses with puberty. Multiple dose basal bolus injections or continuous infusion are used. And please don't use pre-mixed insulins with children. It's of no value. We must use the basal bolus injections. The basal 40 to 50% and the bolus 50 to 60%. It should match the prandial insulin dose of carb and meals and use insulin analogs to reduce the risk of hypoglycemia. Of course, we all know the types of insulin. We have the ultra-short insulin, the regular, the intermediate acting, the glargine, which was described to act for 24 hours, but sometimes it's repeated every 12 hours. We have the detamir, or the levemir that we all know, and recently we have the degludec, which acts for 36 hours, and this is what we call the Tresiba. It's a recent type of insulin. And this is the self-monitoring of the blood glucose, at least prior to meals and snacks, occasionally postprandial at bedtime, prior exercise, or if you suspect hypo or hyperglycemia, after treating hypoglycemia until normal glycemic. I'll speak very few words on the insulin pump. This is one of the technologies in type 1 diabetes. It's a small thing like the size of the mobile or even smaller. It's attached by a needle in the abdomen, and it pumps insulin over 24 hours, as you see. It's flexible and physiological, decreasing insulin requirement. It was described to reduce the risk of hypos. And of course, it requires well-educated parents to know how to do the carb counting and how to use the pump. Of course, the drawback of the pump is that it's very expensive, and sometimes there are technical difficulties in dealing with the pump or finding the accessories. And this is the logbook of the pump, how it looks like. And sometimes you can use the continuous glucose monitoring with a sensor-augmented pump therapy, showing you, as you see here in the curve, 24-hour record of blood glucose. And this is to show you how it looks like. It draws a graph showing you the blood glucose measurement all over. And it shows you the estimated A1C and the blood sugar readings and the carbs entered. So it's very advanced, and there are different models and types of insulin pump. So what are our glycemic targets when using insulin or pump? Again, these are the ADA guidelines for the target of blood sugar. Less than 7.5 A1C is the recommended. If you can make it 7, it's okay. But if the patient enters into hypoglycemia, go back to the 7.5. The fasting sugar 90 to 130. At bedtime and overnight 90 to 150. These are the cutoffs that we use for children. And please remember this slide. Management of diabetic children should be individualized because every patient has got his own story. I can't just put a fixed schedule for every child. Every child has got his eating habits, his exercise habits, his sleeping habits, so we should individualize so that we could match every diabetic story. And this is a small hint on the blood sugar correction factor. We have two rules. The 1,500 rule, where you divide 1,500 on the total daily dose of insulin if you are using regular type. And the 1,800 rule, you divide 1,800 on the total daily dose if you are using the ultra-short acting insulin. Let me show you an example to apply how we can correct the blood sugar if it's high. If we have a 5-year-old boy on a total daily dose of insulin 20, ultra-short and glargine, what's the blood sugar correction factor? Okay. 1,800 rule divided by total daily dose. So 1,800 divided by 20 equals 90. This means that every unit of ultra-short insulin you will inject will lower the blood sugar by 90 milligrams per DL and so on. So it's very easy to calculate the amount that you will correct with. Adjustment of the dose is important. Higher doses are needed with infection, low physical activity, some drugs, stress, adolescence, and pregnancy, and lower doses are needed with higher activity and impaired kidney function. And then the diet. We need a dietitian skilled in diabetes, 3 meals and 2 snacks, and a well-balanced diet in order to maintain healthy pattern of diet, growth, development, and puberty, and to avoid complications. About 55% carbs, 30% fat, 15% proteins, and high fiber diet. And this is how the plate of a diabetic child looks like. And of course, the choice is really difficult when choosing between the sweets and fruits. Again, junk foods are not recommended because they are full of sauces and esterified fats and things that could raise the blood sugar. And then we shift to what we call the carb counting. Each 15 grams carb equals to 1 dot. And the insulin carb ratio, we have the 500 rule, 500 divided by the total daily dose of insulin for rapid acting insulin. Even for foods that are not homemade, if you have chips, if you have a chocolate, anything, you will have the carbs, you can convert it into dot and calculate the amount of insulin needed. For example, here, if we have this label, we will look at the total carb, it's 20 grams, we will calculate the insulin accordingly. If we have a 5-year-old boy on total daily dose of 20, we said each 15 grams of carb equals 1 dot. The insulin carb ratio, 500 on the total daily dose. 500 over 20, this is 1.5 dots. So each 1 unit of short acting burns 1.5 dots. So if the child eats 3 dots, you will give 2 units of short insulin and so on. But to be honest, not all children are able to go on the carb counting. Sometimes they just eat and give themselves the insulin shots. And then we have exercise. encourage physical activity 60 minutes a day, save pre-exercise blood glucose above 100, reduce the prandial insulin dose pre-meal or snack, and reduce the basal the night before if the child is going to do intense exercise. Management of hypoglycemia is important. We give 15 to 20 grams for individuals, measure the blood sugar after 15 minutes, and sometimes we use glucagon injections if the child is not conscious. Don't forget to screen and manage nephropathy, retinopathy, dyslipidemia, celiac disease, hypo and hyperthyroidism because they could occur. Again, diabetes education is very important. It is the way to success. We must educate diabetic patients and their families in order to know the complications, to improve the knowledge skill, and to know the nature of their disease. A way of education is camps, because kids love camps, and we have a lot of diabetic camps. Children are together, they share their experience, they feel that they are not the only ones having diabetes, they measure the blood sugar together, and they take the insulin together, so they feel better. Another question, the vaccine. Which vaccine shall we give to diabetic children? The ADA recommendation is the annual influenza vaccine after 6 months, pneumococcal after the age of 2, and hepatitis B after the age of 19. Another question, to screen or not to screen the SIBs. Considering relatives of type 1 diabetes for antibody testing may allow identification of those children at an early disease, although the ADA did not recommend it as a fixed thing to do. And these are the future options, if you see: immune modulation, B-cell transplant, and the closed loop pump. And finally, some diseases go this way. This is a straight way when you have the disease and you have the management, and some are like this, an interconnected, difficult pathway to go through, and this is type 1 diabetes. It's really, really difficult to manage. And after organizing our thoughts, let me go with you a flashback to the scenario that we started with. We need to close the scene now. What about the mother or the father who have a child with newly diagnosed type 1 diabetes, asking the very difficult questions to answer that I started with? I think the key is motivation at this stage. We don't have to do more. We give the treatment, but we have motivate. Telling them, yes, you can. Because even on a cloudy day, the sun should be shining somewhere, maybe. There are treatments for many diseases, and there is a lot of ongoing research on type 1 diabetes. So there could be a treatment at a time, a radical treatment. Until then, we should try to make the children in a friendship with the disease. Hello, diabetes, will you be my friend? This is what we're trying to work upon. Let them try to cope with the disease. Let them live with the disease to lead a better life. Together, diabetics could have smiling faces at a time with the support of the family, the school, the educators, the diabetologist. And this is the first prize winner, drawn by one of diabetic children. And here she wrote, الإنسولين يصل بأطفال السكر إلى بر الأمان. It was very nice to have this concept from a 9-year-old child with type 1 diabetes. Thank you very much.
شكرا للأستاذة الدكتورة رشا طريف على هذه المحاضرة القيمة والبرزنتيشن الفوتوشوب النايس جدا.